Well, good afternoon, everybody. My name is Mary Larimer. I'm a professor of psychiatry and behavioral sciences and psychology here at UW, and it's my pleasure to introduce our speaker today. Dr. Myra Parker received her bachelor's degree in human biology from Stanford University. She then went on to receive a JD from the James E. Rogers College of Law at University of Arizona, as well as an MPH from the School of Public Health at the University of Arizona, before completing her PhD in the School of Public Health here at University of Washington. She is now an assistant, about to be an associate professor at the Center for the Study of Health and Risk Behaviors here in the Department of Psychiatry and Behavioral Sciences. And she also directs the Seven Directions Tribal Public Health Institute here at UW. So Myra has worked for 10 years on tribal public health program implementation in coordination with tribal communities in Arizona, Idaho, and Washington, as well as with tribal colleges and universities across the United States. Prior to embarking on her career in research, she worked for 5 years in the policy arena within Arizona state government, in tribal governments, and with tribal working groups at the state and national levels. Her research experience in public health involves community-based participatory research and disparities research with a focus on cultural adaptation of evidence-based interventions. And she's going to talk to us today about culture matters, using CBPR approaches to culturally adapt EBIs in American Indian and Alaska Native communities. So welcome, Myra.
Thank you, Mary. Thank you for your introduction, and thank you all for coming. It's a pleasure to be here today. Before I get into the presentation, I want to acknowledge the grant support that we've received from the NIAAA. Also, some of the work that I'll be talking about today was supported by the Frontiers of Innovation project at Harvard University, the Administration for Children and Families, and Robert Wood Johnson Foundation. All of those sources made this work possible. This work is my own and does not represent the views of any of these funders, and I have no conflicts to disclose. So today I'm going to talk about how culture matters when we're developing public health interventions, including those that focus on behavioral health with and for American Indian and Alaska Native communities. By doing so, we can address urgent public health needs, and I'll share some examples of this with you. However, the integration of American Indian and Alaska Native cultures into health research remains uneven and is still in its early stages. Community-based participatory research offers an important approach to improving the cultural fit of public health interventions, and I'll share a few examples of how we've used CBPR in our work with tribal colleges and universities, urban Indian organizations here in the Seattle area, and another tribal community here in the state of Washington. CBPR and the research that came through that process has helped these Native people participating in programs and interventions to be able to reflect on their own behaviors, engage in the program activities, and make changes in their behavior and how they think about the world and their place within it. So cultural frameworks provide members of groups with a specific vantage point in order to interpret the world, their relationships, and their place in the community. We learn these aspects of culture from even before birth. And so understanding how culture might be leveraged to promote positive, healthy behaviors offers an essential upstream approach to addressing health disparities among American Indians and Alaska Natives. By integrating culture, we as researchers, health providers, and program managers can help to promote a sense of inclusion, engage the interests of individuals and communities in the health intervention that we're promoting, and support positive relationships towards improved health outcomes. So first of all, I want to talk about, what do I mean by culture matters in public health? The first example that I'm going to share with you, and this is on the handout that is sort of circulating just so you can see it a little bit more clearly, comes from the American Indian Services Utilization and Psychiatric Epidemiology Risk and Protective Factors Project, or we call it for short SuperFIP. It's a 1995 study aimed at estimating the prevalence of psychiatric disorders, lifetime and current, and service utilization among 2 American Indian tribes between the ages of 15 and 54. The main takeaway from this particular paper that came out of this very large study is that utilization of traditional healers was significantly higher in the Southwest tribe as compared to the Northern Plains tribe that participated in this research. Particularly for those presenting with substance use disorders. In particular, men from the Southwest tribe were significantly more likely to seek traditional healing help compared to men from the Northern Plains tribe. And why is this important? So if we're talking about, offering traditional healing, it might make sense to be able to know, ahead of time where these cultures are at in terms of help seeking, particularly with regards to maybe certain genders are more likely to be interested in seeking traditional healing support for substance abuse disorders in particular, as compared to other groups within American Indian Alaska Native communities. So this is a really great example, I think, and one of the first examples in the research literature of how culture really drives health utilization for American Indian Alaska Native communities. Another example comes from the Northern Plains communities as well. And this is from a 2013 study, which surveyed American Indian Alaska Native moms, teens, young adults, and healthcare providers on their knowledge of the effects of the human papillomavirus, or HPV. As you can see, only 29% of the teens that were in the study knew that HPV can cause cervical cancer. More disturbingly, only 70% of the healthcare providers knew that HPV can cause cervical cancer. Similarly, only 40% of healthcare providers correctly identified HPV as a widespread risk. So in some of these communities, we know that in the Northern Plains, gender roles remain very traditional. And discussing sex and risky sexual behaviors is not necessarily a normative event within these communities. There's an urgent need, therefore, to understand how to best navigate these cultural norms in order to promote accurate understandings of HPV risk and how to reduce one's risk. So for example, in this particular study, you can see that there are a number of different opportunities in looking at different folks represented across the community, from everyone from the individuals at risk to people that they may rely on for information, including their parents and potentially older young adults, and also healthcare providers in terms of education and addressing some of these issues of understanding about transmission of HPV and how maybe to best target, those folks who are particularly at risk in terms of the teens. And of course, I want to, highlight the Healing of the Canoe project, which came out of work done here at the University of Washington with Dennis Donovan and Lisa Ray Thomas at the Alcohol and Drug Abuse Institute. In their work with tribal communities locally, they were able to craft a culturally grounded intervention to address suicide risk, along with substance abuse issues for teens. And so culture is very tightly interwoven in this intervention. And they were able to work very closely with tribal researchers in order to be able to make that happen. So this is another earlier example of how culture can really play an important role in terms of making sure that teens are interested and engaged in addressing substance use issues and potentially other behavioral health issues associated with that. And another sample of the way that culture can play an important role in health services research and behavioral health research is the Canoe project. And this was done with urban Indian teens in the Oakland area in California. And this was, it's still a little bit in its developmental stage, but one of the most interesting things about this is that even when these teens are interviewed through focus groups and interviews, there was still a strong interest in maintaining cultural ties, though they had been perhaps 2 or 3 generations removed from their parents living within a reservation environment. And so, even though, we may assume that urban youth don't have the same cultural connectedness as reservation youth, it's important to note that there's a high interest in learning about their culture and in understanding how their relationship to their culture can inform their behaviors and the way that they see themselves and their identity. So for example, when they talked with the youth involved in the study, they found that there were safety concerns that youth articulated. There were a lack of resources, that children were having a hard time, finding food in the refrigerator to feed themselves on a day-to-day basis. And they were also dealing with historical trauma effects. And some people hypothesized in the focus group discussions that they had that sometimes parenting skills might not be where they ideally should be, because they attended boarding schools, which were mandated for many generations within American Indian Alaska Native communities. And so there wasn't that opportunity to learn from their actual parents. They instead were maybe reproducing dynamics that had occurred within the boarding schools. In addition, students also articulated that they experience high levels of peer pressure and stress from having to compete regularly with their colleagues within their high schools, and also pressure to use drugs. And so there were a lot of instances in the focus group discussions about youth articulating, these are some of the stressors, and we're also interested in learning about what are some of these traditional roles that we can understand and maybe learn about in order to maybe change the way we're thinking about some of these things that we're experiencing day to day in our school lives. So I've given you a little bit of a brief idea of kind of how different researchers are approaching culture and how they're integrating it into public health work and behavioral work that they're doing with tribal and urban Indian communities. And I also want to give you a little bit of an idea of why is this such a big issue for American Indians and Alaska Natives? As I mentioned earlier, Indian boarding schools still remain a root cause of trauma effects for American Indians and Alaska Natives. Colonel Richard Pratt, who was the founder of Carlisle Indian School, one of the largest boarding schools that was in the East Coast in the early 1800s, said that a great general has said that the only good Indian is a dead one, and that high sanction of his destruction has been an enormous factor in promoting Indian massacres. In a sense, I agree with the sentiment, but only in this, that all the Indian there is in the race should be dead. Kill the Indian in him and save the man. So this is an example of the approach that boarding schools deliberately took in order to forcibly assimilate children who came through their systems into the mainstream American culture at the time. And these boarding schools still exist today. Of course, the mandate is a little bit different, I hope. But these are still institutions that people rely on for educational support. And so, I think, as you can see in the photo, people came through these institutions and they dramatically changed in terms of their identity. And it wasn't necessarily an option, it was something that they were required to do. As a result, we still see a lot of types of trauma effects within our populations. There's a lot of family disruption. American Indians and Alaska Natives are disproportionately represented in the foster care system. 6.3% of children in the foster care system in Washington State, for example, are American Indian, even though American Indian children represent only 1.5% of the overall population of children in the state of Washington. And you can see that, in the WWAMI region, I highlighted in this sort of pink color, there's still disproportionality across other states as well, including Idaho, Montana, and sadly Alaska, where there's a really high rate of American Indians and Alaska Natives in the foster care system there. Family disruption also negatively affects other social determinants of health, which of course in turn drive our propensity for risk for other types of outcomes, health outcomes and behavioral health outcomes. So American Indian Alaska Native high school graduation rates are significantly lower than white graduation rates. Only 62% of American Indian students graduated from high school in 2018 compared to 83% of their white counterparts in Washington State. And American Indians and Alaska Natives are disproportionately represented in the juvenile justice system, with 4.7% or 4.7 times higher than white juvenile justice system representation in Washington State. And you can see that those states with kind of the brick red color have the highest disproportionality. Some are even higher than Washington State. So that's a little bit about kind of the snapshot of some of the things that we're seeing across the population, both nationally as well as within specific states where there are a high number of American Indians and Alaska Native represented in the state population. And so I want to also highlight how the integration of culture and health research remains uneven, and perhaps talk about some of the opportunities and the gaps that we can address in our work here. So, I won't go into a lot of detail, but those boxes that are highlighted are actually interventions that were tested that included culture as a primary component in the intervention. And so Hansen and Jensen in 2015 saw that including elder support helped to reduce the risk of alcohol-exposed pregnancies among American Indians and Alaska Natives in the Great Lakes area. Culturally grounded interventions for childhood obesity were found to be effective in the Southern Plains region with John Lowe and other authors. The Apache-centered suicide prevention effort has been shown to be effective, and that effort with Johns Hopkins University has been going on for, I think, a couple decades at least, if not longer, with both Apache and Navajo communities in Arizona and New Mexico. And interestingly, in addition to kind of these handful of actual fully developed interventions, there are some suggestions in the literature that there are some opportunities to include culture in other important ways. So, for example, Molly Fuentes, who actually is at Children's here in Seattle, did a study with children with disabilities, and she, in her qualitative exploration, came to understand that there was a really strong interest with participating in cultural activities. However, the access to these activities was prohibitively high because there weren't sufficient accommodations made. Another example is that American Indian Alaska Native cultural cues, that should be cues, sorry, it's like cures. Cues support HPV vaccination among some communities in the Northern Plains. And so what that means is that they actually identified a handful of kind of, I guess, promotional sayings that they integrated into the intervention and asked people in focus groups, what does this mean to you? Does this help you think about your behavior differently? And they found that that was the case through some qualitative work. And also, again, Dan Dickerson from California has done a lot of work with urban Indian youth and found that American Indian culture offers relational grounding for interventions with youth that he had worked with in the Los Angeles area, I believe that was. So the problem, though, is that there are still some misconceptions about what culture actually is and what American Indian Alaska Native culture actually is. And this is out of an article that was published last year, where the authors contended that the implementation of federal off-reservation boarding schools in the late 19th century, massacres, broken treaties, the loss of land, and forced relocations and coercive sterilizations in the 1970s have become a source of culture for American Indian Alaska Native people. And I think it's really important for us here today to understand that that's a very misguided statement and flawed because those things represented sources of trauma. It doesn't necessarily mean that that trauma has now engendered a cultural movement within American Indian Alaska Native communities. And so I think, that's a really important takeaway from what I want to share with you today, is that when we're thinking about integrating culture, we have to do it really carefully. We have to be very thoughtful about it. We have to consult people very carefully and think through, what are we actually learning about these particular cultures that we want to integrate into our perhaps evidence-based interventions, or in our work developing culturally grounded interventions from the ground up. because we really have to understand exactly what those cultural components are. And that's the challenge, because it's not necessarily out there in the research literature. You know, there's a smattering of articles about some pieces of ways to integrate culture, and less is known about how to actually measure these cultural pieces and how they might be integrated into health interventions more broadly. For example, you know, one of the things, you know, in terms of addressing this historical trauma, and this is something that we've grappled with repeatedly across the work that I've done, and I'll talk about it in more detail a little bit more later, is that this notion of historical trauma and understanding what it means both to individuals and to the communities is really difficult to understand and also difficult to address in a way that is meaningful and yet is not engendering new trauma. And so what I mean by that is that, and I think this gets back to that citation that I shared with you on the previous slide, there can be kind of this assumption that, well, we've all experienced this historical trauma and therefore it's part of us. And so addressing that in a meaningful way can be really challenging. And so I think, you know, some of the work that Maria Braveheart did in the early 2000s is really important, and this can potentially shed some light on how to move forward and how to address it, and yet not get into this, you know, cycle of sort of reestablishing it as kind of the reason of everything and why it's everything is, you know, kind of problematic in our communities. And so what she's found in her work is that helping people identify ways to help others, how to hold on to traditional values, how to form strong attachments, and how to focus on future generations, as well as helping people develop their own identities as helpers and healers, are potential ways to address historical trauma and also heal from it, instead of focusing on it in a very negative way. So I think that that might be, you know, one of the things that we can continue to explore in the research, because we don't really truly understand, you know, what that means across populations. You know, this is just one snapshot from Lakota community members. And so what I think would be another avenue of research is to continue to explore that across different tribal groupings, because there are dramatic differences and variability in terms of different cultural values and norms across tribes, the 574 tribes now that are recognized in the United States, as well as different experiences in terms of what kinds of trauma different folks experience. So I just wanted to give you an example of kind of some of the historical trauma that I know about from my tribe. You know, early in the 1800s, there were several smallpox epidemics that swept through the Mandan and Hidatsa tribes on the upper Missouri and North Dakota. And we have some, I guess, anthropological reports of kind of the trauma that was experienced, you know, when those occurred, and reports of folks, you know, who saw the villages and who saw people who were really sick and obviously dead, and they decided to stay away from the villages because they saw that the disease was ravaging the population. And so that's, I think, something that still comes up today, you know, in discussions with folks at Fort Berthold, where I'm from. In the reservation era, you know, there was a huge change in terms of whether or not people were allowed to leave the reservation. They didn't have the ability to travel as they once did for hunting purposes and gathering purposes. We were an agricultural tribe, and so we always lived on the bottomlands of the Missouri River and grew corn and beans and squash. So we may have felt that differently than other tribes that were more centered around hunting and traveling, large distances in order to be able to make that happen. Catholicism was a big change. That's my grandmother holding my mom in the early 1900s through the 1950s. And then in 1953, I believe it was, the Garrison Dam was erected by the U.S. Corps of Army Engineers. And so it flooded out our reservation. And I'll show you a photo of it later on. But that had tremendous effects because those same bottomlands then that we had traditionally used for farming were flooded out and they were no longer accessible. And so that completely changed the way of life that people had relied on for thousands of years. In addition to that, then that's a picture of my mom at boarding school. We also had, folks who were shipped off 300 or more miles away from home in order to attend boarding school. And so that again was another example of historical trauma. So, I count myself as really lucky. I think there are a lot of people at home who have done their ACE scores and who have really high ACEs. And I've been really privileged because our family has been able to time and again kind of overcome some of these major traumatic events. And I think, what helped me, I guess, understand, how to think about this was actually reviewing this history of my own community and then understanding, okay, how do I understand, what happened to me and how can I then extrapolate, where do we go from here with other tribes and other communities and other examples of historical trauma? Because sometimes understanding it and acknowledging it and kind of accepting it is at least a small step towards this path towards healing. I also then wanted to share with you, I'm just kind of looking at the time, a few examples of how community-based participatory research offers a remedy to begin to understand how to address cultural fit and improve cultural fit in public health efforts. So I mentioned earlier that, I'd show you a picture of our reservation at Fort Berthold. One of the things that CBPR focuses on is a whole host of actually 9 different principles. And I'm not going to go through every one of them today, but I did want to highlight a few of them. And one that's really important for American Indians and Alaska Natives is recognizing community as a unit of identity. And I think if we as researchers and healthcare providers and other people involved in health and public health can understand, what that really means for different communities, I think that that is one way to then think about how to come at our work with a culturally informed lens. So, for example, in the work that we were doing at Fort Berthold, we realized, it's one reservation, and so we could survey the entire reservation, but we also need to understand that the flooded area actually kind of bisects the reservation. And so some communities are less accessible to other communities. So we then needed to think about how to weight our sample appropriately, because we knew that there were some communities that really didn't, if we only sampled on one side of the river, for example, we weren't going to get a comprehensive representative sample. So that's one example of kind of how thinking about community can actually inform the work that we're doing. Similarly, this is a picture of King County, so in our neck of the woods. And what I did for the home visitation work that I'm going to share with you in a little bit is I was looking at all of the zip codes, and I was highlighting those zip codes that had more than 100 American Indians and Alaska Natives living within that zip code, according to the 2000 census at the time. And so you can see that there's a little bit of a pattern. And I don't know if anybody would want to hazard a guess about what the pattern represents. That's really great. Yeah, absolutely. Close to water. It's also right along the I-5 corridor. And so that was really helpful for delivering a home visitation intervention, because in terms of deciding recruitment strategies, deciding about scheduling home visits, we needed to take that into account, because we knew that home visitors were going to have to get on I-5 in the middle of the day and potentially spend 5 hours on the road trying to get to a family in the South King County area. So So that's another way how we can use CBPR principles to inform, our program planning and implementation in order to better address, the lived experience. In this case, it's not necessarily cultural. It may be that it's close to water as well, because the Duwamish, who traditionally are from here, definitely, this is their territory. And so of course, they might live there, but for other purposes, like contextual purposes of, where people are living, it's also important to kind of address it from that perspective as well. The second CBPR principle is to build on strengths and resources within the community. And so one of the things that we've done with Ina Macaw, the home visitation program that I mentioned, is that we're working with local schools to do some of the recruiting, because we know that moms who receive the newsletter from their local school and see Ina Macaw may have younger children at home and therefore may qualify, or they may pass it on to their neighbors. We also are working with tribal programs, because sometimes there's a lot of movement between borders. And so even though people are currently residents of, the Muckleshoot Indian community, for example, there's a high likelihood that they may move to the Seattle metro area. And back and forth. And so that's another opportunity for, I think, some of the work that you all might be interested in doing locally. I just had somebody reach out to me this morning, actually asking me for ways to outreach to all of the medical care providers who work with American Indians and Alaska Natives in the state of Washington, because there are some opportunities for reimbursement that they want to share through Medicare and Medicaid. So there's, I think, a lot of opportunities to use CBPR to kind of understand what are some of those institutions, what are some of those community efforts that are occurring locally in order to best deliver the services, and potentially also to then structure the research in important ways. The Indian Health Service, although locally that's not necessarily something that's as prominent as in other regions, it's also the main funder for a lot of programs that are delivered here in the Seattle area. And so there are then restrictions around that funding. And so it's important to understand kind of how that informs the ability of, for example, the Seattle Indian Health Board to partner with you and to work with you in certain projects. And then there are, tribal leaders or congressional leaders or other folks who can be really instrumental in serving as kind of that community champion in order to push the research forward, or to help to identify other resources that you might be needing in order to make your research occur. And finally, parents. I think, one thing that we learned when we surveyed American Indian Alaska Native residents here in the King County area was that people get information from a variety of ways. And so we listed all kinds of things on social media. We listed newsletters, we listed other web-based sources, telephone, and it was really interesting because when we got the results, people had kind of ticked off every single box. So they use everything. There's not necessarily like a clearinghouse of information that's out there in this particular region. And so so we do a lot of word of mouth. People actually, the home visitors went out to grocery stores, and they went out to libraries and primary care facilities to try to find parents and just canvass the area in order to get the word out about the home visiting program. Another CBPR principle is to address health from both positive and ecological perspectives. And so one thing that I think is really important, and I feel like I'm still trying to integrate into my work, is including a strengths-based approach and ensuring that culture is a part of the decision-making process. And what I mean by that is that, some of my colleagues here worked on the Tribal Colleges project with me, and Bonnie Duran, who was the principal investigator, and we put together, I don't know how many items on a really long survey that lasted probably like an hour at least, maybe an hour and a half. And we had combed through the literature, we thought we had done all of our homework, and we brought it to the tribal college presidents, and we asked them to review it. And this was all according to CBPR principles. And they looked at the survey and they said, this is really great. It's probably really important. The problem is that it's all problematizing our communities. So you are measuring depression and foster care contact and juvenile justice contact and all of these really negative things that we know are related to our health, but we already know that. What we don't know is what are some of those positive things that are helping our people survive and to build their resiliency. And so we were kind of like, wow, I can't believe we did that. And we learned from it, I hope. And we went back to the drawing board and we combed through the literature again, and we looked at resiliency measures, and we looked at some of the social support measures that were out there. And we did ultimately include some of those measures in the survey. But I think that that is something, you know, that I'm really grateful for, because I feel like if I hadn't been a part of this process as a junior investigator and had that feedback from community and seen kind of what that relationship looked like in the midst of this research, that would be maybe a mistake that I would make in the future as well, you know. So I feel like, you know, there are some opportunities for learning at every level. And I think that CBPR is something that, you know, if you come to it with an open mind and kind of an understanding that you're going to make mistakes, and it's probably going to work out if you're real about it and discuss it with people and not try to hide it, then I think, you know, there's some real opportunities to do better research in the end. So I want to give you a few examples from my work and leave a couple minutes for questions about how I've done some work looking at how to integrate culture in home visitation and some other projects. So you don't really need to know kind of the logic model ins and outs, but this is our logic model for the Tribal Home Visitation Project that United Indians of All Tribes Foundation is funded to do. They're an urban Indian organization here in Seattle. They're coming up on their 50th anniversary. They're located in Daybreak Star, which is in Discovery Park. It's a really amazing social service organization, as well as a cultural center for the urban Native community here. So this is what we had to do for our federal partners who funded the project, try to find, you know, how do we map out our goals and what kind of resources can we bring to bear, what are the activities that we're going to implement, and what do we hope to have as outputs or outcomes from this project. And so one of the first things that we had to do was to decide what we wanted to do with the program. And the way that we did that was through engaging the community through a whole series of focus groups. And I think we ultimately ended up conducting about 12 or 15 focus groups across the Native community, both with elders and with parents, youth, and service providers. And all of that information was just a rich source of kind of the how-to of sort of how to make this program more relevant for the community here in the Seattle metro area. And one thing that we found was that there was a really wide variety of cultural experiences. And so from this particular person, they were adopted. She thought that she was Filipino, and when she found out she was Native, she thought, oh, I'm like Pocahontas. And she says, you know, that's what you see as Native American in mainstream culture. And it's so much more than that. It's so much more than that. So this is an interview that we conducted with her at the end of the program, after she had had the opportunity to work with a home visitor and attend group connections on a monthly basis for at least a year and a half. And so at the group connections, that was a primary piece of kind of how we integrated culture, how we brought opportunities to parents who may never have known their family to bring their children to and to learn about themselves, and then be able to continue that learning with their child even after, you know, the group connection. So this is another example of kind of one of the things that we were able to develop through the focus groups that we conducted early on in the program development. One thing that we heard in both the survey that we implemented and the focus groups, as well as information from service providers, was that stress was a major factor for a lot of the folks who were parenting who are American and Alaska Native. And I don't think that that's necessarily novel for parents in general, but I do think that one of the things that is different is that people may not know how to manage stress in a healthy way. And so we took a stab, we combed through the research literature again. We were looking at, what are some of the culturally specific ways that people manage stress. There actually isn't a lot out there. There is probably more now because there are more studies that are being done on traditional healing and meditation and kind of that whole intersection. But at the time, about, I guess, 8 years ago, that wasn't necessarily the case. And so we were just kind of trying to offer some suggestions to parents. And we offered them also some ways to think about, how they're going to actually change their behavior and actually try to manage their stress and set some goals. So this program participant noted that I have the stress handout. When I got it, it was kind of just the right time. I had a job interview coming up and I just found out I was pregnant again. It was really stressful for me. I think it really helped me get through the process. It gives a lot of ideas about what to do when you're in a really high stress situation, like how to calm yourself down, even if you're a really high stress person. So we had some really positive feedback from the cultural adaptation handouts that we developed, like that stress handout that I just shared. This is another handout that we developed. This is all kind of based off of the Parents as Teachers curriculum, so we kind of use the same formatting in general, but we included specific resources for help from this region. And we talked about how to deal with domestic violence and sexual abuse, which actually was not something that was included in Parents as Teachers at the time. So there were sort of generic discussions about how to be safe, but domestic violence was never actually mentioned in the Parents as Teachers curriculum. And what we found in our surveys and in our focus groups is that people were really ripe and ready to talk about some of these hard issues. And that was surprising to us because we hadn't really thought that people would be willing to delve into some of these really challenging and difficult issues within the community. And so, one participant noted in the focus group that it turned out really nice for my family. We get a lot of support, and it's really nice to know that people who are in the program and know that there are people here we can meet for emotional support. So that was one thing that we found, was that at first there was a huge hesitation to having a home visitor come into the home and sort of see, your life. But once they made that connection and built the relationship, both with the parents and with the child, that then shifted. And there were people who actually didn't want to leave the program. And they were talking about getting pregnant to stay in the program. It was a joke, but it was very nice to have that kind of feedback, that they appreciated those relationships. And then back to historical trauma, we, again, didn't really want to bring up a lot of issues for folks, but we also knew that we needed to acknowledge it. And so what we did as kind of like a strategy was to make it an optional topic. So people didn't have to use this content, and the home visitor ahead of time previews the next meeting's content with the family. And so in this particular instance, she asked people, is it okay to talk with you about historical trauma next time? It's an optional activity. You can certainly say no if you want to. And so a lot of people actually ended up discussing it. And I know this is a long quote, but I thought it was really important. This was a home visitor who came from the Southwest and who grew up on a reservation. And she said that Ina Macaw reminded me about values that a lot of Natives have, like be true to yourself, think positive, and see all the possibilities. When I was growing up, my grandma and my aunts were like, you shouldn't think negative thoughts about people. It was like practically witchcraft. In my experience, it was really nice to have that reminder about different values we have as Native people, like with being healthy and historical trauma effects. For example, we never had fry bread before contact. It's nice to pass that on to our children. We're Native people, we don't eat fry bread. We have a healthy meal system that we had before we had lard and flour and coffee beans. Yeah, it's just nice to instill those values. And one of the other participants in the focus group, I remember, who actually was adopted, said, and if you don't know, it's important to learn them and find out about them. So that was really interesting too, because there was a lot of bridging across different lived experiences, where there were folks who were very deeply embedded in their culture and had grown up around it, and other people who were just learning it brand new. But there was that sharing that the program actually helped to support, and support as a result of kind of the comfort of being able to discuss some of these challenging things. So I mentioned the tribal colleges and universities study earlier, and I just wanted to give you an example of one aspect of it. So we worked with 7 tribal colleges across the country, and we were implementing a brief alcohol screening and intervention for college students intervention, which Mary Larimer has been developing, and Ty, over many years, but we culturally adapted it, or we tried to. And one of the pieces that we added in was a poster series, so that we had these door-sized posters. There were 13 of them, and we put them up in the college library or in their lunchroom or in the hallway where a lot of students would pass through. And we wanted to share the information about basics, but in a culturally relevant way. And so I worked with some of the representatives from these colleges to develop the posters through a series of different calls and meetings over like a 7-month period. And so this is one example of part of the poster for one of the colleges. So you can see that, you know, the feedback was that they really wanted to see something from where they're from. They wanted to also have tribally based value systems woven into the posters in order to make it relevant for the tribal college students who were viewing them. And then we also added in some questions at the end of the poster, so that we could ask people to reflect on some aspects of it, so that as they were going through the poster, we hope that they were kind of having this moment and space to think about, you know, the relevance of this information for them and their communities. We did address historical trauma again in the posters, and we were encouraged by our advisory board and also the folks who participated in the poster development to address it head on and be brief, but, you know, be realistic about it, and also then portray, you know, how people actually see themselves, which is strong and resilient against history. And that was something that came out of this work with the community members, and we relied on CBPR as a way to make that happen. This is part of the standard feedback through basics, but what we did was we made it relevant for tribal college students by using their own data, so that they could see that the norm for drinking was maybe a lot lower than what they had anticipated that it was. And we also included culturally important locations in the poster imagery to help kind of center the importance of this work for the tribal college students. And currently, I'm working on a new study, What is in Your Heart? It's based at the Colville tribe, and we're culturally adapting attachment vitamins, an evidence-based trauma-informed parenting intervention for tribal members there at Colville. And usually, you know, it's a parenting class kind of setup with 10 weekly meetings. They're facilitated by community members. It's a psychoeducational curriculum, including a reflective discussion among the caregivers and sharing moments of connection. And that's kind of the it of the intervention, an opportunity for parents to understand, you know, what their relationship is with their child, and being able to reflect on it in the moment. And so one thing, you know, that has come out of that work initially with discussions with the tribe is that there's a strong interest in culturally centering this work. There's a strong interest in integrating cultural practices, so being really specific about ways that tribal members think about parenting in terms of even using native terms in their own languages. There's 12 bands represented at Colville, and so that's a little bit of a challenge, but we're trying to work through that. And also to identify ways that we can support relationships in a meaningful way. And so those are some of the early discussions with that new work. In closing, to save just a couple minutes for questions, integrating culture can help strengthen provider and family relationships. Excuse me. It heightens interest and engagement of participants and supports ongoing identity development across generations. And it also centers American Indian resiliency and healing. And I just want to say Madzigiradz, which means thank you, and Hidatsa for your time today. I really appreciate this opportunity.
who was doing the at-home visits? Social workers or other people?
For the Ina Macabre, oh, you're right. Thanks, Ty. Ty's the pro at this. So the question was, who was conducting the in-person visits or the at-home visits for the home visiting program? And it's actually an array of folks. So there were folks who were high school graduates, and there were also people with their MSW. It's designed, Parents as Teachers is actually designed to be open for anybody to serve as kind of the home visitor. I think one thing that United Indians had to be careful about was that, you know, as somebody who had the cultural humility to be able to work with families in the home. And so I think that was what they really focused on in the hiring process. So not all of the providers are Native, about half of them are, but they had worked with Native communities before, or they had worked with a large number of clients before, and so they kind of had an idea of how to navigate some of those questions. Did you have a question?
I'm just curious if you could talk about the decision to make the historical trauma module optional, why that one specifically versus the others?
Yeah, so the question is, why was the historical trauma module optional? When we conducted the focus groups to develop the Ina Macabre program, we conducted, I think, 4 different, or maybe it was 6 different focus groups with elders. During that process, they really wanted us to address historical trauma with parents, because I think they wanted parents to understand kind of the legacy of kind of some of these traumatic events in history and how it may have impacted what they received when they were children from their parents. And the stories that they shared were very difficult to hear, actually. Some of them talked about abuse, sexual abuse, physical abuse in boarding schools. They talked about some pretty severe examples. And so I think initially people in the program were a little hesitant to try to kind of address that very specifically. And we actually had a scientific and community advisory board for Ina Macabre, and they recommended that we make it optional so that people would have the choice. And actually, I think only one person refused it. I think everyone else decided to go forward with the optional module, but I think it was just kind of in the trying to be as careful as possible and sort of meet families where they were at. You know, if they were willing to talk about it, great. If they weren't, then we needed to adhere to kind of their own preference. Okay, well, it's 1 o'clock, so I guess I'll close with that. And thank you so much for coming. Appreciate it. And have a great rest of your afternoon.